Hi, and thank you for joining us right here at the San Antonio Breast Cancer Symposium. My name's Todd Hartley, and I'm joined right now by Dr. Jay Harness, a past president of the American Society of Breast Surgeons. Dr. Harness, welcome back to San Antonio.
Hey, it's good to be here, Todd. It's a wonderful building and a huge turnout, and lots of our friends are here. And we were here last year and had a great time. We might even share with the folks how good it was last year.
Yeah, last year we had 163,000 views to this broadcast. And what we're going to do is we're going to tell you about the big news that's developing right here in San Antonio. And for those of you who may not know, this is the biggest breast cancer conference of the year. And it's a real honor to be able to sit next to Dr. Harness another time around to bring the news to experts.
Yep, it really is. And I actually think, Todd, it's probably the largest breast cancer meeting of its kind in the world.
Wow.
The two meetings that are really important are this meeting and also the ASCO meeting. And so people who have breaking news, the latest in research, they like to have their studies presented here.
And throughout the year, you and I hear this time and again, we could be meeting with a device manufacturer or a diagnostic company, and they could say, well, we'll tell you this, but that's not allowed to come out until San Antonio.
That's right.
Why is that?
Well, first of all, people are very concerned that their research remain private until it goes public. A lot of the paperwork that we've got here now and news releases are embargoed until the day that they're released, and then it goes out to the world, basically. And it's kind of the way it works, basically.
So if Dr. Harness just alluded to embargoed press releases, you'll see right up here on the top, it says embargo, right? So we've had this for a couple of days, but now we're going to be able to talk about it. Before we get into these articles, Dr. Harness, let's paint the picture for people who are somewhere in the world, but they've always wanted to come to this conference. Let's just give them the full scope of it, the size, and what they could expect in the volume of people.
Yeah, I don't know what the actual numbers are this year, but generally this meeting has well over 10 to 15,000 people, Todd, who show up for the meeting. These are really the leading breast cancer researchers from around the world, PhDs, MDs, large number of medical oncologists who are here, probably not as many surgeons as myself who are here, although I've seen already several of my distinguished colleagues who are here. And so, yeah, it's huge. And not only is there the benefit of the general sessions, where the latest and greatest is presented, and we're going to try and highlight some of those for our colleagues this afternoon, but also it's the interaction that goes on, the informal conversations. As I've walked around the convention area, I see groups of people in groups of 6, 8 talking about studies and collaborating and doing things like that.
So isn't it a great opportunity that you get experts from around the world, and there's so many different languages that are being spoken here. It's crazy. You're walking down the hallway and you all of a sudden forget you're even in America because there's so many different languages. But this is one of those opportunities where somebody in another country can meet with an expert and they could be collaborating on what they're getting to advance overall patient outcomes.
Absolutely true, and we're really blessed, and blessed is the right word in the world of breast cancer, because among the solid organ cancers, we probably have made more progress in breast cancer than almost any other solid organ. Now, great progress has obviously been made in leukemias and lymphomas, but in the solid organs, probably the great progress has been made in breast cancer, not only because of the international collaboration, but also because of really excellent funding.
Awesome.
Yep.
So in the interest of full disclosure, Dr. Harness and I together run breastcanceranswers.com. We do these hangouts for the lay public, and then once a year we come and get to do this for the expert community. And I happen to be a husband of a breast cancer survivor and also the son of a breast cancer survivor, and it's a subject I'm passionate about. So let's kick off some of the news. Now, it's late here in San Antonio, or late in the day at the conference. People are starting to already trickle out and then go to their dinners. Their presentations just go around the clock. And if you walk outside this door that we're in, and you walk out the door at 9 or 10 o'clock, there's still people coming out of different sessions that are going on. And down the hall from us is the press room, and the press room is ginormous, and it can seat almost 300 people. That'll give you the scope of what an event this is. Dr. Harness's first embargoed press release that we saw, benefit of breast cancer screening more consistent across studies than previously understood, and it says here that, well, look, you're the expert. I'm just working my way through this. What is this study about?
Yep.
What's
Well, my colleagues know that one of the big controversies right now is the value of breast cancer screening, namely screening mammography. And are we getting our bang for the buck, so to speak? In other words, per how many patients that are screened do we actually find a breast cancer? And we've got studies, Todd, that are from all over the world that vary on a low end of every 111 patients screened, we find a new cancer, to as high as 2,000. So there's great variability. And what was done in this study, and the friend of Breast Cancer Answers, Dr. Robert Smith, PhD, who is the Senior Director for Cancer Screening at the American Cancer Society, presented this study. And basically what it did was to take the Nordic review study, the Nordic Cochrane review study from the UK, which is Independent Breast Screening Review, the US Preventative Task Force, we've done videos about them, European Screening Network, taken a bunch of studies, put them all together, and then tried to figure out a commonality among the studies, and that if you really reorganize the studies so that there's a commonality, maybe there isn't so much in the way of disparity between the studies. Now, one of the things driving this, quite honestly, is the cost of screening mammography. Are we going to have limitations done in the United States and elsewhere in Europe because we don't get that big a bang for the buck? And basically what they did was to try and bring the studies together with common follow-up, common age groups, what have you. And so for the purpose of the review, they used the United Kingdom's sort of methodology. They had screening of women done over a 20-year period. The age group that was being screened and bringing the data together was age 50 to 69. And they looked then at breast cancer mortality down the road. And what they basically found was that there wasn't that huge disparity of how many women you had to screen in order to find a positive breast cancer. And it went from 111 up to 2,000, contracted down now to 64 to 257. In other words, the studies narrowed. And what the studies, when you narrow the way you do the studies, actually what it finds is the studies are effective. And so we generally talk about in the United States, somewhere around every 100 to 110 people screened will find a new cancer. We're really right in the ballpark. So I think what this basically reaffirms is screening mammography done with mammograms is here to stay. There isn't as big a disparity as we thought, and hopefully we'll continue to have the kind of funding going on that needs to go on and to keep this kind of effort alive and well. How does that affect you? I mean, you've got a wife who is a breast cancer survivor. Actually, in Wendy's case, her mammograms couldn't see the cancer, but she felt the lump, and she was just in her early 40s and had, I think, started some breast cancer screening already, correct?
Yeah, that's correct. We had our eyes on it for a while. We knew there was at least some type of fibrous cyst issue going on.
Yep.
And it was because of that routine screening that we were able to catch it early.
Yep. And I want to share with my colleagues that we have yet to invent the holy grail of breast imaging. No single one technology tells us all. Digital mammograms are as good as it gets in mammography. Certainly, ultrasound is really helpful, Todd, in the really densely breasted patients. and you're going to be hearing more and seeing more in the future about whole breast ultrasound screening for breast cancer. And then the ultimate gold standard right now is breast MRI. When we combine all of those technologies together, we get the best results. But I think the bottom line clearly is now in the asymptomatic patient, screening mammography is where the action's at to screen large numbers of people. So this was an important report, and I'm glad that we shared it with our colleagues.
Well, news every day is going to be thick coming out of the San Antonio Breast Cancer Symposium. I know that Dr. Harness and I were tipped off about this study, I would say 3-4 months ago, that the results would be here.
Yep.
And interesting enough, it's the first one that we get to talk about.
Well, and we did. We had Dr. Robert Smith with us at Breast Cancer Answers doing a live Google Hangout. He once again reaffirmed the American Cancer Society recommendations to start screening at age 40 and to do it annually. And then those women who are over 70 and healthy, they should continue to be screened.
Is there some controversy in this? I mean, this seems a little bit different than what the U.S. Preventative Task Force came out with, 3 years ago?
Yeah, in that ballpark.
Is there controversy here?
Yeah, there still is. The task force basically wanted us to start screening at age 50 and start looking at every other year. Again, I think what bringing these international studies together and the recommendations, there's a little more uniformity. We're going to keep going the way we're going in the U.S. That's
pretty
good
cool.
news. Okay.
So just a little tidbit there. My wife was screened 9 months before, totally clear.
Yep.
And so, I mean, the annual really benefited us because we got her back there.
Yeah, it not only did that, but Wendy also had a lump that was palpable in her breast, and we went then to diagnostic studies. Ultimately, her ultrasound was the key factor there. And that's why I was saying earlier, we're going to need in the future things like nuclear medicine imaging, whole breast ultrasound imaging as a way of dealing with the really densely breasted patients. Well, why don't we move on? Let's move on.
So patients with metastatic breast cancer may not benefit from surgery and radiation after chemotherapy. Interesting news release.
Yeah, this is in my real world of breast cancer. Fortunately, because we have so many people being screened, we don't see a lot of patients, Todd, who come in already stage 4. But this is an extremely well done study from the group in Mumbai, India. I've got lots of colleagues in India. It's not at all unusual for patients to come through the door already stage 4, meaning the cancer has gone elsewhere in their body. So one of the big, huge debates then is what is the value of local regional control? And by local regional control, I mean what's the value of a lumpectomy, radiation therapy, what's the value of a mastectomy? In other words, to get rid of the primary cancer when you already know that somebody is stage 4. At my hospital, St. Joseph Hospital in Orange, California, we're participating in a U.S.-based clinical trial on this very subject, but this is a huge report coming out of India involving hundreds of patients who were randomized into 2 groups, basically. One group, of course, got chemotherapy to help control their cancer, but did not then get any follow-up local regional control. By that I mean mastectomy, coupled with radiation therapy, etc., versus the other group that did. And what they found here was that there was no difference in overall survival between the 2 groups. I'll read from the report. They found that the median overall survival of the local regional control group versus no local regional control was 18.8 months in the local regional control, and the ones that didn't get it, it was 20.5 months. Statistically, there's really no difference. Now, having said that, there are reasons to do local regional control, particularly in those patients whose cancers are growing out through the skin These are fungating cancers that may not go away completely. But we're talking about quality of life issues here. That's not reported, at least in the information that we've got now. And so patients may actually benefit from local regional control when it comes to quality of life issues. But when it comes to overall survival, there's no difference. I'll be anxious to see over the next several months or next few years with studies being done elsewhere if they match up with the study coming out of India. But I think this is an important contribution.
My favorite line as a layperson, because there's really not a lot I can contribute on this, is that the clinical trial was funded by the Tata Memorial Center and the Department of Atomic Energy Clinical Trial Center in India. And if I have to go to the Department of Atomic Energy for a clinical trial, then I'm not going. That's scary.
Well, but you know, even now, here's one that you're not aware of as a layperson: our military, actually, the Army and others actually fund and support breast cancer research here in the United States. So basically, where you can get the money, you get the trial. Okay.
Really interesting. And who knew there was a Tata Center?
Yes. Who knew?
I have no idea.
All right.
All right. So avoiding radiotherapy, avoiding radiotherapy is an option for some older patients with breast cancer. Dr. Harness, this news release just dropped today. What's the takeaway from this?
Well, my colleagues, I think, already know this, but I want to repeat it. And that is that breast cancer is a galaxy of diseases, from basically very benign acting to super aggressive. And all of us in the field know this. And so the question then becomes, in invasive breast cancers, in women older than age 65 or 65 and older, is there, and they have lumpectomy, and they've got smaller cancers under 3 centimeters in size, is there really a benefit to the radiation therapy? Now, my good friend and colleague, Kevin Hughes, from the Mass General, has been publishing about this for a long period of time. This particular study comes from the Edinburgh Cancer Research Center at the University of Edinburgh, Scotland, and it really supports a lot of what my good friend Kevin Hughes has been talking about. Basically, this study showed that when you avoided the radiation therapy, that basically there wasn't a big loss, if you will. In other words, out of every 100 patients that you avoided radiation therapy in, 1 patient recurred because of the biology of the cancer. 4 patients recurred because they didn't get radiation therapy and they were dealt with adequately down the road. But 95 out of 100 patients in this particular study really didn't benefit from having the radiation therapy.
Wow.
Now, there's some really...
That's remarkable, isn't it?
Yeah, it is. And again, what we're trying to do, and we have been for 10 years or more, is trying to personalize cancer care. We know right now that in situ breast cancer, that a assay like the Oncotype test for DCIS may help us to predict who's not going to benefit from chemotherapy. And my feeling is that more and more of the genomic assays are going to tell us up front who these patients are. Now, that kind of data from what I've got here is not blended in with the report. Basically, these were all women who were 65 and older. They had hormone-positive breast cancer. They had low-grade breast cancers. They did not have any disease in their lymph nodes. And obviously, they didn't have any distant metastatic disease. So basically, these were small cancers, think under 3 centimeters in size, stage 1 breast cancers. The key here is the low grade. The key here is that they were all hormone receptor positive. Besides the surgery done adequately with adequate margins, radiation therapy was avoided, and they got the appropriate anti-hormonal therapy. And so I'm not surprised by the results of this, but I think it really goes on to helping to support what my good friend Kevin Hughes has been talking about.
You know, the line in here that keeps screaming out at me is what this study shows is that for every 100 women treated with radiotherapy, 1 will have recurrence anyway, 4 will have a recurrence prevented, but 95 will have unnecessary treatment. That's amazing.
Yep, and that's what I was, trying to say sort of a minute ago, that actually the 4 that I was talking about would actually have their cancers prevented. I'm not sure I said that correctly just a couple of minutes ago. So yeah, so basically the benefit is 4%, if you will, which is an extremely low number. And as I said a moment ago, I'm personally convinced with the genomic assays that we're doing, we'll probably sort out even better who the patients are that don't require adjuvant radiation therapy. Good study.
Really interesting what's coming down from the San Antonio Breast Cancer Symposium. Dr. Harness and I are going to be here each night reporting to you what's coming, the latest news, and what we're hearing on the floor for what it means to help elevate patient care. Let's go off to the next one. High levels of immune cells in tumors may identify breast cancer patients most likely to benefit from
trastuzumab,
a word I'm not going to say on camera.
There you go. Or the easy one, Todd, is Herceptin.
Herceptin. Sure.
You've heard of Herceptin,
yes.
Right? Yeah, this is really fascinating. This is a fascinating study that comes out of Melbourne, Australia. Now, when we talk about tumor-infiltrating lymphocytes, this is all part of the immune response to cancer. All of us in the field have been asking ourselves for decades, Todd, why does the body recognize cancer as non-self and churn the immune system loose on cancer? And the reality is, and in fact part of that is sort of the basis of thinking now about trying to create tumor vaccines. In other words, if we can, in an individual patient, make a vaccine that allows the body to turn on these killer lymphocytes, basically the patients ought to do better. There may even be spontaneous remissions, etc. So let me sort of read from this. So what this study looked at was with HER2 new positive breast cancers who had the highest levels of immune cells in their tumors gained the most benefit from neoadjuvant or preoperative chemotherapy and trastuzumab, or basically probably the regimen here was TCH. And so we know that these cells are important. We obviously know that TCH given in the neoadjuvant setting has an effect, but what they found here was that the higher levels of tumor infiltrating cells, as those levels went up, the complete pathologic response of the TCH neoadjuvant chemotherapy went up as well. In fact, they reported that for every 10% increase in the levels of tumor infiltrating lymphocytes, there was a 16% increase in the number of patients who had a pathologic complete response. The paper then, or the release that we've got, then talks about other mediators to try and boost the tumor infiltrating lymphocytes. I'm not going to go into the details of this, but if we can add other mediators that basically increase the number of tumor infiltrating lymphocytes, then perhaps we can make our overall chemotherapy really work better. We're going to be adding additional blockers. This is all part of more in the way of targeted therapies. What I would want to say on this particular subject is basically stay tuned.
And stay tuned, because all week we're going to be bringing you the latest information. Dr. Harness, do you know what goes into, and if you don't know, tomorrow I'll get our audience this answer, but can any company put out these press releases here, or does it have to get reviewed?
Well, first of all, I don't think a company does it. Second of all, the papers selected for here in San Antonio, including the posters, are all peer-reviewed, Todd. So nothing gets presented here, and I don't know what the acceptance ratio is. Maybe we can find that out.
I'll get that answer.
Yeah, but if I had to make a guess right now, for presentation at a plenary session here with 5,000 or more people sitting in the audience, my guess is you're talking about 1 out of 10 that gets submitted for a presentation. Now, we have a large number of posters here, and we're also going to be looking for breaking news from the poster sessions. But this is a highly selective meeting, highly selective. The bar is set very, very high to have anything presented here, and clearly is peer reviewed before it even gets to the floor.
Wow, that's pretty cool.
So the press releases then, I believe, are a summary done by the San Antonio Breast Cancer Symposium staff. It's actually put out by the staff, not by the companies. And it's trying to summarize the presentations prior to publication. Now, one other thing that I would suggest for colleagues and even patients who are watching this live Google Plus Hangout is that you can go to SABCS, which stands for the San Antonio Breast Cancer Symposium, and I believe it's .org, and you'll be seeing releases coming there. Also, if you Google this conference, the highlights of the news releases are coming out, so anything you've missed that we've shared here will be available on the internet as well.
So for more information on the San Antonio Breast Cancer Symposium, like Dr. Harness mentioned, SABCS.org. That's San Antonio Breast Cancer Symposium, the acronym, .org. And the mission of the 2013 San Antonio Breast Cancer Symposium is to produce a unique and comprehensive scientific meeting that encompasses the full spectrum of breast cancer research, facilitating the rapid translation of new knowledge into better care for patients with breast cancer. And as you can see, it's starting to really, there's really interesting information that's coming out, but it's starting to really pay off in patient outcomes, as this stuff comes, to practices.
Oh, well, there's no question about it. And just like there are the best of ASCO meetings that are held subsequent, there are the best of San Antonio meetings held as well. And now those may be company sponsored, particularly if a company's had a good result presented here and they want to get the word out to all the practicing medical oncologists, radiation oncologists, and surgical oncologists.
Now, Dr. Harness, we have one left tonight to talk about, and that is the study identifies high effective treatment options for patients with HER2 negative, positive, HER2 negative, positive?
No, positive.
HER2 positive.
That's HER2 dash
thank you.
Positive. Todd.
HER2 positive breast cancer. Let's talk about this study.
Yeah, this is called the BETH, B-E-T-H trial. Again, we're all looking forward to the publication of this. This is really an important trial. Now, before we ever had Herceptin, before we had trastuzumab, if you will, we've been using adriamycin and epirubicin for a long time. These are the anthracycline type of chemotherapies. And when we've looked in retrospect and then realized with chemotherapy with adriamycin that we got good results, we now know that a large percentage of those good results were actually in HER2 new positive breast cancer patients. Well, with the advent of Herceptin, and then adding, and then also looking at Avastin, we now are starting to ask more and more questions. Are they equally as effective as with adriamycin? Now, the big thing with adriamycin is the physicians know is we worry about late onset leukemia, we worry about late onset congestive heart failure. And while trastuzumab has those effects too, the incidence of having those, Todd, is infinitely lower than it is with adriamycin. And even with adriamycin, the numbers are low. So this looks then at basically two cohorts. This enrolled over 3,500 patients in the BETH trial. The majority of them, 3,200 patients, were in cohort 1. In cohort 1, randomly assigned patients to either TCH or TCH with Avastin. And then cohort 2, which was much smaller, only 278 patients, then allowed physicians to also have an anthracycline-based therapy as part of the regimen with or without Herceptin. Much, much smaller group. And what's sort of the bottom line of this? Well, at 38 months of average of follow-up, they found that the disease-free median survival was 92% in both arms of the TCH cohort, meaning that the addition of Avastin really didn't add anything, where what's really effective here is TCH. And then they also found that the adriamycin group had basically a little bit lower disease-free survival. In other words, the TCH was as effective. Bottom line is, we don't need to be adding adriamycin to the treatment of HER2-positive breast cancer. I think this study, the best study, is going to be another one of these that's going to be a game changer.
Wow. Well, it's interesting to see what's happening here at the San Antonio Breast Cancer Symposium 2003. Last year, we were lucky enough to bring these news updates directly to you. We recognize that a lot of you are, or a vast majority of the people out there, are actually practicing and not able to come out to San Antonio. So it's an honor to be able to bring this information directly to treating physicians.
Absolutely, and we'll try and add more, but again, I would emphasize we're just touching the tip of the iceberg here. I would really encourage people to search the meeting on the internet. There's going to be more and more information pouring out of here. Subsequent publications are going to be real important as well.
Well, on behalf of Dr. Jay Harness, my name is Todd Hartley. We are grateful that we're able to share this information. Coming up tomorrow, we're going to be back here to give you more information developing in San Antonio. We'll take the day to digest it, to talk with other key opinion leaders to see what's developing, and we'll look forward to bringing that information to you right here on Google+.